Okay, so when a patient can't breathe, every single second is a race against time. Today, we're going to pull back the curtain on one of the most intense, high-stakes procedures in all of emergency medicine, securing an airway. We're diving into the powerful drugs that let doctors take complete control in a moment of pure chaos, turning a dangerous fight for air into a precise, life-saving move. Let's get into the science behind it.
Just look at this. This is the reality of the ER. You've got a patient who's fighting for every single breath. Their body is worn out. Their oxygen is dropping fast. Now just try to imagine putting a breathing tube down the throat of someone who is awake, panicked, and actively fighting you. It's not just hard, it's incredibly dangerous. This right here is the life or death problem that modern pharmacology was invented to solve.
So how do you get from that chaotic struggle to a controlled, successful procedure? I mean, you can't just ask a critically ill person to hold still and say, ah. You need a method that's standardized, super fast, and really, really reliable. And that need is exactly what led to the development of a very specific protocol for these moments.
And that game-changing solution is called rapid sequence intubation, or RSI. The idea behind it is actually pretty brilliant. You use a powerful sedative to make the patient unconscious, and then you immediately follow it with a paralytic to relax every single muscle in their body. In less than a minute, you create the perfect, still conditions to safely place that breathing tube. It's basically a controlled chemical takeover of the body's most important functions.
Now, the full protocol has a lot of steps, but it really boils down to these 4 key phases. First, you prepare everything, all your gear, your team, and you get as much oxygen into the patient as possible. Second, and this is the main event for us today, you push the meds. This is where pharmacology takes center stage. Then, with the patient asleep and paralyzed, you place the tube. And finally, and this is so important, you prove it's in the right spot. You have to be 100% sure air is going into the lungs, not the stomach.
So let's break down that critical second step, starting with drug number 1. This is the induction agent. Its one and only job is to flip the off switch, taking a patient from awake and struggling to completely unconscious, usually in under a minute.
But here's the thing. You can't just grab any drug off the shelf. The patient's specific problem, whether they have a bad head injury, really low blood pressure, or a massive asthma attack, completely changes which off switch is the safest one to use. So how on earth do doctors make that choice?
Well, this table lays it all out beautifully. Let's say your patient is having a severe asthma attack. Ketamine is an amazing choice. Not only does it sedate them, but it also helps open up their airways. It's a bronchodilator. The downside? Something called emergence reactions, which just means they might have some wild dreams or feel confused as they wake up. Now, for a head injury, you're probably reaching for etomidate. It's known for being really stable on blood pressure. Its main drawback is adrenal suppression, which is a fancy way of saying it can briefly weaken the body's stress response. And then you've got propofol, which is great for someone who's having a seizure, but you have to be ready for its biggest side effect, a pretty serious drop in blood pressure.
All right, so the patient is now unconscious. But believe it or not, that's only half the battle. To get the best view and prevent some really bad complications, you also have to hit the pause button on every single muscle, and that's the job of the next drug, the paralytic.
You might be thinking, hold on, they're already asleep. Why is this so important? And that's a fair question. The thing is, even when someone's unconscious, their body still has really powerful reflexes. A gag reflex firing off at the wrong time could make them vomit, and if that gets into their lungs, it's a disaster. Paralysis just erases all those reflexes. It makes the jaw go slack and keeps the vocal cords perfectly still, giving the doctor the best possible shot at getting the tube in on the very first try.
For a long, long time, the king of paralytics was this drug, succinylcholine. It works super fast and it wears off quickly, which is a great safety feature. But it has one big risk. It can cause a dangerous spike in potassium in the blood, something called hyperkalemia. And that's bad because high potassium can cause deadly heart rhythms. So you don't want to use it in patients with, say, kidney failure or major trauma. That's where its main rival, rocuronium, comes in. It's almost as fast, but it lasts way longer and it doesn't mess with potassium. Plus, and this is a huge deal, you can actually reverse it with another drug if you need to.
So let's put this all together. The real skill of RSI isn't just knowing about these drugs one by one. It's about picking the perfect cocktail. The right sedative paired with the right paralytic for the specific patient that's right in front of you.
And this slide shows exactly how it works. For a patient with a traumatic brain injury, the protocol points right to etomidate because you desperately want to keep their blood pressure stable. Then you pair it with succinylcholine for that super fast on, super fast off effect.
Every single choice is made for a reason, all to maximize success and minimize risk for that patient's unique problem.
Now let's go back to that asthmatic patient from the beginning. For them, the cocktail is completely different. Here, ketamine is the star of the show. That unique ability to open up the airways isn't just a side effect, it's a huge benefit. You're actually treating the underlying problem at the same time you're getting the airway. It's a perfect example of precision emergency medicine.
But, as powerful as RSI is, it's not a silver bullet. The second you push those drugs, you are all in. You've taken away the patient's ability to breathe on their own, and there's no going back. And in some situations, the risk of not being able to get that tube in is just way too high to take that leap of faith.
You have to think about other options if, for instance, a patient has a known physical issue with their airway, or a neck injury that means you can't position them right, or maybe even a tumor blocking the way. In those cases, if you commit to RSI and you can't get the tube in, you're in big trouble because now they can't breathe at all.
So what do you do then? Well, this is where clinicians pull out some really advanced moves. There's awake intubation, where you carefully numb up the patient's airway while they keep breathing on their own. Or delayed sequence intubation, which uses a bit of sedative, often ketamine, just to calm a patient down so you can load them up with oxygen before you commit to the full procedure. These alternatives show you just how much skill is involved in managing an airway.
So there you have it. We've seen how a couple of drugs, chosen carefully and given in the right order, can turn absolute chaos into a controlled medical procedure. This incredible pharmacological control is really at the heart of modern emergency care. And it makes you wonder, right? As we get even better and smarter with these drugs, what other impossible situations are we going to be able to control next?